to the Davies Use Case webinar being presented by Cleveland Clinic on VitalScout. This is a use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promote of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. It recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable and improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our speakers for today's webinar from Cleveland Clinic, and Brent, to introduce yourselves.
All right, thank you, Arno. This is Aaron Hamilton. I'm a physician here at the Cleveland Clinic and serve as the medical director for patient safety.
Good morning. I'm Sue Collier, the Chief Nursing Officer for Cleveland Clinic Hillcrest Hospital.
Hi, I'm Kathy Burns. I'm a clinical nurse specialist for Medina Hospital, and I'm the clinical lead for this project.
Hi, good morning. My name is Suzanne Fink. I am a nurse and technologist with the Cleveland Clinic Emerging Clinical Solutions Center team.
Hello, my name is Brent Hicks. I'm the Senior Director of the Emerging Clinical Solutions team here at the Cleveland Clinic.
Great. So this is Aaron again. I just wanted to start with some framing comments about how important this project has been to us as a health system, and I have a spin towards patient safety. So I think what's really spectacular about this work and really impactful is that we've partnered successfully together with our information technology team to take a very complex set of information and data from our electronic health record and distilled it to something that's really elegant, simple, and meaningful in a visual way to our entire care team, which also includes our patients. And so that has been a tremendous win for all parties, probably most of all our patients. And we are just thrilled to share this work with you. We're really happy about how we feel this can be translated into other health systems to really lead transformational change in how we think about early warning systems and identifying and caring for and driving actions around patients that are deteriorating under our care. So with that, I'm going to hand it over to Sue Collier for a couple more comments.
Thank you. So this whole idea started with just one patient and the story of that patient and how we could have impacted the outcome to be better than it was. It started at Medina Hospital, as you'll hear soon, and they really worked on refining it and making it really visual, as Aaron mentioned. And that's important. With so many new nurses hired every year and many of the new grads going on to the night shift, they needed to have a better process for understanding patient condition. And this really tells them a story that empowers them with that knowledge so they can translate it to the physician when they call about a patient situation. So with that, I'll turn it over to Brent, and he can begin to relate how this all came to be.
Thank you, Sue. So, yeah, as Sue mentioned, without getting too ahead of myself and looking further into the project, it was from the outset identified that we needed to employ a clinical decision support process at the heart of this solution. So looking at the current offerings within this realm, obviously we have paper from the past that is in the past, and we are somewhat limited to the EMR tools that are provided for clinical decision support. And these are, they do great. These tools do a great job saving people's lives, med errors, all sorts of allergy med every day. Thousands of patients are saved by these tools. But for the kind of project we were looking at, we wanted to enhance these tools, and we wanted to, instead of with the focus being on one patient, we wanted to focus on a population of patients. And so we were kind of looking at the concept of real-time population health within a whole health system or within health facilities. We also wanted to create a system that created accountability. So within that situational awareness, we could actually treat this as a team sport and tag in when we saw that there was a problem that was actually going wrong with some of the patients within these tools. And we also wanted rich visualization tools. So for a lot of our projects, this one included, we tried to employ a design process methodology, and also for this project, we took an agile approach to how we developed the tools. So for the design approach, the emphasis is on understanding the problem and not jumping to solutions, which fits very well with the agile methodology too. Also, we try not to be limited by our knowledge of what tools that we have available, so we try and keep an open mind, listen to the users, understand what the problem is, try and work together to figure out what the best solution is, and then based on that, try and frame the technology around the best possible scenario that the users can want. And sometimes that means looking beyond our team, sometimes that means looking beyond our industry for inspiration and ideas about how we can kind of bring some of these other concepts into healthcare to kind of move the needle forward. So the agile process that we took was just to meet with the users, understand what their problem is, talk to them, observe with these different two approaches. Just by talking to users, you kind of get the obvious things that are within the solution that you're trying to create. Observing users, you get the implied things. Users often think that you're just going to inherently understand what their workflow is because they do it all the time. It seems very obvious to them. So you kind of start to understand implied aspects within those workflows. But the fastest way is to actually start prototyping and creating and getting these tools into the hands of users, into a production system. It doesn't have to be a perfect end solution. It doesn't have to have everything, all bells and whistles working, but you can get the framework of an idea, give it to some users, get them to use it, get them to run with it in a production system, give you feedback, go away, make some changes, and then move forward. So we approached it this way, and within 2 or 3 months, we had a pretty good solution figured out that's been refined and honed over the years. As this product or suite of solutions has gone to different facilities, we've actually got different ideas and thoughts from the different users, and we've been able to fold those into the solution. So those have been spread out across the whole enterprise as it's gone across the different health system. Outside of the classic EMR tools that we had, we're able to employ our web service broker, which is a FHIR-enabled common service layer, which sits on top of our EMR and allows us to send data in and out of our EMR and expose it to the web. And that means our endpoints or our applications that can live on top of this can be like anything from mobile, desktop, Internet of Things, whatever, smart on FHIR or FHIR-enabled. So that gives us an extra kind of edge in our toolkit. We also employed the R statistical platform to enable us to refine the predictive model that we ended up using. Also, we are able to use that to create use cases to test the myriad different outcomes that these scoring systems can create to make sure that we were accounting for all the different workflow nuances that occur on the floor. And we also use that for creating some descriptive statistics to help us with our metrics as we've moved forward over the last couple of years with this solution. So now I'll hand it over to Suzanne Fink.
Thanks so much, Brent. So as we heard from Dr. Hamilton and Sue this morning, we heard about how this began with the story of one patient. And here at Cleveland Clinic, that's actually the heart of our mission of Patients First, is really to think about our patients and their individuality, but also to think, starting with that one patient, to look at the broader problem both here in our Cleveland Clinic enterprise and all of our community regional hospitals and our main campus, and then even how this is such a problem nationally, which is, I think, what inspired us to tackle this. We know that preventable medical error remains the number 3 cause of death in the United States by many estimates, and so this is a challenge that sets the bar very high for us to really innovate and to figure out why technology isn't fully budging that needle and how we can employ technology best to really serve the needs of our patients and our caregivers. So the Association for Healthcare Research and Quality really defines failure to rescue well by capturing the idea that we know we can't prevent every complication of medical care, but that we as healthcare providers should be able to rapidly identify and treat these complications when they occur. And we want to maximize our ability to do that with this program, and we believe we really have started on that journey. We know that 80% of cardiopulmonary arrests have signs of deterioration in the preceding 24 hours by many studies. Some studies even go as far as 48 hours or beyond. And it's also clear from the literature that it's felt that greater than half of these events are felt to be preventable. And so really, when we started to look at the broader situation beyond just the one incident of inspiring failure to rescue, this was the issue we felt we wanted to tackle the most. We wanted to study first, well, let's get a real understanding of the time that our patients spend at this high acuity that puts them at risk for acute decompensation that we could then subsequently miss. So when are our patients at that highest risk? And so we developed a scoring system and algorithm, which you'll see shortly, that helps us to measure the percent of time our patients spend at high acuity. And here you can see from the graph that I'm showing that average over the 2 facilities that we studied, representing about 1 million hours of care, showed that it was anywhere from 5 to 10%, and this is averaged out, so we've seen it be as high as 12% and as low in some cases as 4%. So there's a great deal of variability, but we were able to see also some consistency across those numbers, and also some cyclical variation with seasons. The next thing that we wanted to look at to start us was the idea of this average time to reassessment. So when we've identified that a patient is at that high acuity range, typically when they have 2 to 3 vital sign aberrancies that are putting them at risk, how long does it take until a reassessment occurs, until vital signs are measured again in the electronic medical record and we can see that thought process loop close itself? And so here you can see we studied our first few facilities, and that time hovers around 2 hours on average, but is often greater than that. And so that helped us to hone in on a target of saying we really want to get to a place where our patients are reassessed within a time frame of 2 hours or less, and we'll get into more detail on that shortly. And as Brent mentioned to start this conversation, a big part of this project and any kind of project that we undertake, especially with Agile methodology, is to really understand the problem fully. And that means, putting your feet on the ground, putting your hands into the work, and really working alongside our caregivers. As a registered nurse, I always say that process for me and for my colleagues begins with looking at our nursing process. And so here I just kind of visually represent that nursing process from assessment, diagnosis, planning, and implementation to evaluation of the patient. And what we can see from this is that we also discovered in looking at each step of the process that nurses were taking as they were caring for our medical surgical patients, we heard about their challenges. Challenges in communication, challenges in managing chain of command. One that really became obvious to us was this transition to practice gap. As a teaching facility and institution, we have many residents, we have nursing residents, we have advanced practice nurses, we have physician assistants. We have a very academic climate that has students and practitioners at all levels of practice and experience. And we found that gap from the classroom to patient care is really where some of the difficulty lies. We also have this preponderance of technology. As a technologist, it's hard for me when my caregivers say to me, the biggest problem I have, Suzanne, is how much technology you guys are throwing at us every day. And so in this solution, we realized we want to tackle failure to rescue. We want to help these challenges, but we also don't want to just throw something else at you. They keep saying, don't give us more, give us something that means more. And there's also a great deal of workflow variance. We have unlicensed personnel that take care of our patients as well, and so understanding the handoffs that occur at different hospital units, at different hospitals, was really, really important to understanding our local problem. Next one. Brent mentioned the topic of situational awareness, and this one is especially special to me and to those of us on the VitalScout team, is this concept of situational awareness. When we met with our caregivers and looked at not just the first failure to rescue case that started this project and really ignited our kind of energy around this, we also started to look at other things that we were hearing about from our nurses, other situations, other things they'd encountered. And the common thread was that our caregivers were reporting to us this loss of situational awareness. Brent mentioned looking outside of one's own department for inspiration, and I was a critical care nurse with our critical care transport team, so very proud of our Clinic 1 helicopter that's shown on the slide here. I was proud to fly on that helicopter for several years and work with our aviation professionals who really take situational awareness to heart. And the key components they always taught us about were that situational awareness encompasses not just being aware of information, but being able to take the information into your brain, comprehend what it means, and use it to project what might happen next. And that stressful situations make this process very difficult, and so being self-aware was really important, but also the idea of leveraging the collaborative and leveraging your team to really bring situational awareness to the forefront. And so as that process kind of began to wrap up our initial inquiry and our beginning of design, we knew that what we needed to do for this clinical decision support was turn data into actionable knowledge. It wasn't enough to just have information coming back out. It truly had to go from visualization or calculation to actual action, and that we knew we wanted to study based on those metrics that we started with, the timely recognition for intervention for early signs of clear clinical deterioration on our medical surgical unit. So Brett mentioned our design process, and I put this slide up because, you know, many times our nurses and staff come to us with this preconceived idea of, you're going to give me another pop-up alert, you're going to give me another thing, I can just document another template, or I can do. And to Brent's point with as technologists, it's very important for us to get people out of that mindset of, don't tell me what you think is going to work, let's talk about what you actually need. And so what you'll see here is one of our early whiteboards that you'll see how it translated later into part of our technical solution that really emerged as we move forward with the VitalScout project. But truly, Agile process is so important to design for us, and it really does allow us to be iterative and get that continuous feedback from our caregivers. So ultimately, our program really resided on these 4 key goals. So the first was we wanted to improve recognition and intervention for those early signs of deterioration. The second was that we wanted to increase the communication and collaboration among all of our caregivers in a multidisciplinary fashiin regarding the significance and manage the subtle changes in patient condition that we know lead to deterioration. We wanted to increase the frequency of vital sign monitoring and reassessments for patients that we identified at moderate or high risk in our early warning system. And we wanted to increase accountability for taking and recording vital signs in the electronic health record in a timely fashion, because what this project really showed our caregivers was that, you know, clinical decision support can be great, but if the data is not in the electronic medical record, it can't do anything with it. And so one of the key agents for change in this program were our patient care nursing assistants who actually record vital signs in the EMR. And they're the ones who have really taken this and pushed it forward. Next one. So our governance strategy, how are we going to do this, and who did we need? And so first we formed our enterprise pilot and core team. So there you can see on the left, we had our project manager, we have our executive sponsors, of whom Sue Collier was one. We have our clinical lead, Kathleen Burns, who you'll hear from shortly, the technical lead, and myself, and Brent Hicks. We had education, nursing informatics, nursing quality, and our physician sponsor, Dr. Hamilton. And then what we realized, to make this successful, to take a program like this and be able to scale it across an enterprise, what it really took was that first piece of understanding, of truly understanding that each one of our community hospitals here at Cleveland Clinic are different. They have different cultures, they serve different populations, and how they embrace change is different. And so our method for scaling a program like this across our enterprise was to form local implementation teams that matched up against that pilot and core team. So you'll see how those roles are shared in the local teams as well. And then our implementation and workflow development process. So first, we did begin at a pilot at one of our community hospitals. We started with that root cause analysis, which has formed as our grounding for this whole project. Our research, our literature, the formation of our team. We established our pilot metrics for success. We had that leadership buy-in and approval, and we performed our different build processes in the agile fashion Brent mentioned. And then we had our pilot. We had a very successful pilot, which led to an implementation review that really brought us to what you're going to see some samples of shortly, which is VitalScout version 2.0. So we are a very metrics-driven program, and we revised our algorithms based on what we learned from that pilot, developed further quality metrics, and then we brought our second hospital online. So our first hospital, we were looking at about 100 beds, and then we went to scale that to about 300 plus. So it was a good experience for us to say, can we scale this first and foremost from a single facility to a second facility, which really set us up to make it an enterprise-wide deployment. We developed a playbook, so we actually have a standardized process now for the rollout of the VitalScout program to each hospital, and we utilized that playbook and refined it each facility we went to. The screensaver you'll see shortly, and who knows what's next for version 3.0. So here's an example of something that, the metrics really taught us. So for our pilot, we started with an early warning system that had only 4 parameters. We started with a 4-parameter model. And we realized very quickly as we were working with our nurses at Medina Hospital, and Kathy can certainly speak to that a little bit, that we felt we were missing something. And so we were able to utilize our data to go back and project, had we included our 5th parameter, which we now include in our enterprise model, would we capture more of the patients and affect more of the change that we wanted to? And we found that that was the case. So this is an example of that quality improvement for version 2.0. I fully expect as we evaluate our progress to date that we'll be making further improvements in the future. And so here's kind of the heart of our VitalScout early warning system. It is a very simple early warning 5-parameter model that looks at pulse, respiratory rate, systolic blood pressure, oxygen saturation, and the presence and usage of supplemental oxygen. From those vital signs, as soon as they're entered into our electronic health record, a score is immediately calculated, which we call the VitalScout score. And that total score, when you see to your right, places you in one of the categories that you see. So green, typically we always say green means go, is our within range value. One of our nurses, in our design process, we actually had this as an orange color, changed it to blue because he said light blue meant 1 clue. And so blue became our awareness level, where 1 vital sign might be significantly out of range, or 2 only slightly so. But we still know that those patients might be signaling a change. Third, you see our caution assess patient, and this we truly say is our golden opportunity with the VitalScout program. These are patients who typically have, multiple vital sign aberrancies that we have found from our research if they are not intervened on within a 4 to 6 hour period, will go on to need rapid response care. Our red level means that the patient needs action immediately, typically a rapid response to be called, or a change in the level of care. It's also important to note, and you will see throughout the remaining slides of this presentation, the presence of the color purple. Purple for us is designates our patients who are do not resuscitate, comfort care only. These patients still receive a VitalScout score because an escalation in score could signal a need for nursing practice change or nursing intervention due to pain, anxiety, or suffering, or air hunger. And so it was important for us to score these patients but not to put them on a reassessment algorithm. It's also important to note from this that nurses can always escalate in our system. There's a button they can press to move a patient from green to red or from green upward to any other color. We know that nursing and medicine are both art and science, and we hear this from our caregivers all the time. I don't want the computer to think for me. I'm a provider. So in this instance, we found that we could marry both of those things very well by saying, the computer is alerting you based off of evidence, but you also have your judgment and can always feel empowered and should feel empowered to use it. So it's also of note, patients in this yellow category are reassessed in 2 hours or less, and patients in red should be reassessed in 1 hour or less. And we'll go forward and see some of the metric results from those guidelines. So here you just see that we at Cleveland Clinic utilize a variety of methods for vital signs getting into our electronic health records. They can get there via HL7 or device integration. We have some mobile applications that also allow vital signs to be entered at the point of care. and obviously manual EMR flow sheet entry. So as soon as they hit our electronic health record, that VitalScout score is calculated. What you see next is the most exciting part, I think, for so many of us of the VitalScout program, and that is our VitalScout literal screensaver, lifesaver. This screensaver is a web-based application that sits on all of our desktops. So here you see an example of an all-unit view for one of our regional hospitals. And what this does is it enables us to display in real time the acuity of our patients and their changing conditions throughout the hospital unit and literally throughout the hospital itself. This screensaver can be applied to any one of our desktops or clinical workstations. To date, it's installed on over 2,500 workstations at Cleveland Clinic. What you see on the screensaver is actually a lot of information. It's quite interactive. So here you see in the upper left-hand corner, the patient has a calculated VitalScout score of 5. As a caregiver, I can click on that tile or box, and it will actually expand in the screensaver to show you the details. Our caregivers constantly told us that throughout this process, don't just show me an alert, show me why it's firing, show me why the computer is telling me what it is. And so here you can see the use of color-coded flags to help inform our caregivers to understand exactly why we're displaying a score of 5 and placing that patient in the top acuity spot. It also shows things like who's on our treatment team, score trends, and key you will also see is this VitalScout timer, it's this VS timer. That's that trigger, that visual alert to our nurses and staff that this patient should be reassessed within that 1 hour time frame or 2 hour time frame. And it also, to Brent's point when he said earlier about using technology to make it a team sport, it took away the idea that one nurse was responsible for the acuity change in his or her patient. It opens the idea that we as an entire care team are responsible for the changing status of our patient. And so now, for me as a nurse, I may not have this patient, but I can see that they've had this acute change, that their oxygen saturation is low, that they're due for reassessment in an hour, but I'm very much empowered to go into that room and take care of that patient myself. And so this has been a significant, for something seemingly so simple, change in our practice at Cleveland Clinic. We also have mobile applications that we've developed, as Brent mentioned, with our web services platform. So here you can see an example of Iris Mobile, which is a mobile app that our physician and advanced nursing practice caregivers can carry around. It also has those VitalScout scores and colors in the same way that you saw in the screensaver. And what we like about that is this connectivity idea of my being able to call Dr. Hamilton, alert him to a change, and he can look at that same data point that I'm looking at, and we can go forward. The next thing was how that visualization and how those special web visualizations would tie back into our core electronic health record. So here you see the view of this is what our caregivers see when they see our screensaver, and then on the right-hand side, what they see when they go into the electronic health record. And again, the data syncs up, the visualization syncs up, the color immediately draws your eye, and you're able to see now the further detail of what's happening in that simple tile. So the tile gives you very minimal clinical information, but enough to help you prioritize your care. Then you can log in and you have all of the details that you need. What's also special is you can see that it lists the providers. So we have a mark as reviewed fingerprint, as we call it, that also enables someone to acknowledge from within the EMR and then out to the screensaver, okay, I've got it. It's the ability for us to say, I'm aware my patient is at that yellow at-risk range, so that when someone walks up to the screensaver, sees that yellow or red tile and says, oh my goodness, what does this mean? They can say, oh, Suzanne Fink is already aware of it, because they can see that from both the EMR record and the screensaver itself. And then lastly, one of the biggest pieces that seemed, again, so simple but was so powerful in this program was to get caregivers literally on the same page. What we heard from both our physicians, physician assistants, nurse practitioners, and nurses was that staff would call the physician and say, my patient's having an acute change or something just doesn't feel right. And they might have difficulty articulating that. And that we found when our physicians pulled up the electronic health record, they were looking at different data than the nurse might be reporting. We weren't looking at the same sources of information. And so what we found was if we could simplify, there's so many reports in our EMR, there's so many sources for data, but if we could whittle it down and provide clarity for nurses and physicians around these acute changes. We studied with our nurses exactly what information do you need to know. I tell you your patient is yellow. what are the things that will help you decide what's driving that? And let's put that information and only that information into the report. Remove the clutter and help you focus. And we found tremendous results by doing this, with many of our physicians almost immediately after go live coming back to us and saying, these phone calls I'm getting are so much more meaningful now. We're able to take action and formulate plans much more quickly because we are quite literally on the same page. We also realized that nurses do so much and the documentation doesn't capture it. And so we created some very discrete, very simple form-based documentation tools to surface in that report and in the screensaver and in other places that key communication links had occurred and that certain information was passed back and forth. And this capture allows us to have this greater transparency around acute events. We're able to much better tell the patient story of who knew what when and what really happened along the progress of the patient's deterioration now because we're capturing that information in a quick but very meaningful way. And so we kind of come back to that place that I started with in terms of looking at the nursing process and designing a technology solution that would support nurses along every stage of that process. And so you see here throughout, it's the report, it's our algorithm, it's our standardization and process, it's the visualization and situational awareness of the screensaver, the quick documentation tools that allow nurses to show the value of their work, and how it all finally ties together, and more importantly, ties our teams together. And so revisiting a bit more what Brent had introduced, this idea of us starting saying, okay, how can we make next generation clinical decision support? How can we introduce better elements and strengthen this effort? And so you see where we started and kind of the things that we added that really added that extra special layer. The situational awareness, interactive visualization, also being able to look at populations. For our rapid response teams at our hospitals to be able to have a list, have their own screensaver visualization that shows the entire hospital. Which patients should we round on first today? To be able to bring that into focus with such a key element of CDS that we've not seen before this solution, and that enhanced accountability. And so the results that we have that we're so proud of to show. This particular slide is really interesting because this was one of the first things after our pilot that told us we were really on to something, especially when it came to the visualization. Kathy really looked at the percent of events occurring within 24 hours admission at our pilot hospital. And we saw an immediate change following our pilot. And we realized this was because the ED would be calling to send a patient up to a medical surgical floor. They would see the VitalScout scores up on the unit and say, is this the right level of care for this patient? Their blood pressure is really low. Are they on the sepsis care path yet? We know that it probably changed decisions, and this is what we heard from our caregivers. And it was one of those things we didn't expect to see right off the bat, but this was an early metric that helped us to understand that this visualization was very important. And then we really look at that time spent at higher acuity. So now this is looking at 2 hospitals who are now starting to go on their 3rd year of go live. So in that data set, you can see clearly how we've dropped significantly every single month, including those immediately following go live, the time that our patients are spending at higher acuity. What we also see, and as you know, as a nurse and sitting here with Kathy and Sue, something that makes us incredibly proud is that target of 120 minutes has been met and completely, they took that and ran with it. Our patients, on average, they've exceeded the goal that we set for them in so many ways on our medical surgical units by reassessing our patients so much sooner. And what that told us from a technology standpoint as well is that our caregivers, our nurses are tremendous. They want to do the right thing. They just need it to be not just on one individual on the team. Our teams are exceptional, and so when we put the challenge out, not to just one person, but say, as a team, we want these patients to be reassessed, our teams can meet that goal every time. And so those first few slides looked at our first 2 hospitals over that, the past few years. Now we are live, have data reported for 6 facilities. We're live in 9. But when we look at the scaling to 6 facilities, we realize that at our baseline, 20% of all of those patients in this cohort were reassessed within 2 hours. After our go-live date, when we look at that data now, 79% of our yellow or at-risk patients are reassessed within 2 hours. This is May of this year. and we expect that those trends will continue as we expand the program, as the numbers have been very consistent. And I love to discuss this idea of green hours, because we set out to look at failure to rescue and to reduce, risk for patients, but we also set out to gain stability. And so the flip side of this discussion is really that we've also gained so many more hours of stability for our patients. So patients who would have spent time with high blood pressure or very tachycardic heart rates or to struggle to breathe are no longer doing that. And so there's also an important conversation to be had in our hospitals of what we can do with those green hours. And we believe our patients will probably go home from the hospital sooner. We believe that they see better benefit from their care while they're here in the hospital. And we also know that that will likely impact, patients' reports of how their pain is managed and many other things. And so I think it's fun when you're talking about failure to rescue to also talk about the other wonderful things that can happen when we gain patient stability. And so on the VitalScout team, we're very fond of saying, what will we do with our green hours, even ourselves, because they represent so much potential. And lastly, from an IT standpoint, I can't say enough what it means to talk about green hours or to talk about these patient care scenarios with your team. Here you see represented many of the areas that touch this VitalScout program and the process of getting it to go live. When I think of all of our screensavers and the field engineers and all of the staff that had to help me to make sure that those are all in functioning proper order. When I think of my developers who I dragged out to the hospital and we sat down in caregiver meetings, and they really had to dive into nursing and to dive into our patient care and to really understand our patient story. And so telling stories is important, and I would express that I think our information technology division was very much impacted by this program, because we took a lot of time as a team to tell our story and to help bring this back to our mission here at Cleveland Clinic of Patients First. And with that, for some more clinical discussion, I'm happy to turn this over to my colleague, Kathy Byrne.
Thanks, Suzanne. As VitalScout has moved across our health system, its impact has really increased exponentially. The sheer number of caregivers and patients being touched by this program really speaks to its impact. We've actually provided VitalScout education programs to over 3,000 nursing caregivers, and then awarded more than 3,000 nursing continuing education credits, so that's huge. Today, we have over 1,700 patient beds that are under surveillance by VitalScout, and over 2,500 screensavers that are running 24/7 and refreshing every 2 minutes. And that actually equates to 11.5 million API service calls each month. And that's just to ensure that the data continues to be accurate and in real time. And what's really fascinating is, despite these numbers, we've only had 21 help desk incidents since we've gone live in 2015. And I think that's a huge testament to the skill and the commitment of our development team. The cost of developing VitalScout was really very low because we were able to leverage our existing resources and we didn't need to purchase any additional technology. The development cost really consisted of the team's FTEs, and we did not need to add any additional FTEs for this. And our training costs were for the hour-and-a-half VitalScout education program that we provided to our nurses and the half-hour training that we provided for all of our unlicensed nursing personnel. What we have found challenging, though, was to really assign a financial return on investment for this project. How do you account for adverse events that never happen? As the number of VitalScout monitored patients grow, we really anticipate being able to identify more opportunities to show return on investment, but we've chosen to highlight 2 examples here. So our pilot hospital was able to decrease by more than a third the number of cardiac arrests occurring on their medical surgical units. And so far in 2017, this hospital has gone on to demonstrate a 50% decrease in codes from those pre-implementation numbers. And you can see those numbers on the slide. The literature estimates that a 50% survival rate occurs for these inpatient events. And then the American Heart Association reports that care typically costs between $15,000 and $40,000 for post-cardiac arrest care. So if you look at an average, there would be a cost savings of about $190,000 from the decrease in post-cardiac arrest care, and that's just at this one community hospital. If you look at moving this across a health system, think of the savings you would have with all hospitals. And while the cost saving is beneficial to the hospital, the true benefit of preventing cardiac arrest is improved patient outcomes and quality of life. So if you look at this from a patient perspective, really the value is immeasurable. Since implementing VitalScout, our 2 pilot hospitals have experienced an increase in case mix index. But despite the increase in acuity, both hospitals have demonstrated a decrease in length of stay. Now, we understand that length of stay can be impacted by many different variables and initiatives that each hospital is doing, but the use of VitalScout to really identify and address signs of deterioration in a timely manner can really improve those patient outcomes and then contribute to this decrease. So to demonstrate return on investment here, 2016 case mix adjusted length of stay was compared to 2015 pre-implementation length of stay. And you can see resulting savings of 2,100 days, which equates to an estimated $900,000 in savings. We looked at qualitative data in several ways. First, we surveyed nurses and providers at our pilot hospital to evaluate user satisfaction with VitalScout and to really ask their views regarding what impact do you feel this had on our patient outcomes. And the caregivers were asked if they felt there were earlier interventions for patients showing signs of deterioration, and then if patients received more frequent reassessment of vital signs following an alert. And in both cases, caregivers overwhelmingly felt that we intervened earlier and we reassessed vital signs more frequently for signs of deterioration. And the majority also felt that there was better management of patient acuity when this program was implemented. We developed a novel education program for VitalScout. While we did demonstrate the technology, the education wasn't about the technology. It was really about focusing the nurses on how to incorporate the tools into their workforce or into their workflow, how to utilize the technology to help them to better evaluate why is this change happening, what is the clinical significance, and then to go on and determine what do I need to do as a nurse, do I need to involve the provider, how do I intervene appropriately. And as you can see, 91% of those surveyed felt that this training really met their needs. We also asked nurses and physicians if they felt the program impacted interdisciplinary collaboration, and 72% felt that it increased collaboration. We also did a qualitative study. Some nursing researchers have suggested that early warning systems may actually take away nurse critical thinking, replacing it with nursing actions done based solely on a score, so that early warning score is visualized and they do something based on seeing a score. VitalScout is not just an early warning system, it's an enhanced early warning system. So while it starts with an early warning system score, it then incorporates the technology and the tools designed to support critical thinking and decision making. So to better understand what impact VitalScout and these tools have on nursing practice and workflow, we did do this qualitative study, and we used an interview methodology to conduct that. So using interview responses, we were able to actually construct a conceptual model that describes the impact of VitalScout. So you see the circles here, and those show that the patient is surrounded and supported by the VitalScout technology. And what nurses told us was that VitalScout directly impacted nursing practice in 3 ways. First, it increased their awareness of early signs of deterioration. It triggered investigation into the cause of deterioration, and finally, it supported prioritization of their care of their patients. That's what we were hoping we would find. But what we really didn't anticipate was the indirect impact the program has had on organizational culture. Nurses shared that VitalScout has led to improved communication and collaboration with our providers, increased accountability for responding to early signs of deterioration, and a proactive rather than reactive response to signs of deterioration in our patients. Nurses also said that they felt the program improved patient outcomes due to earlier recognition of deterioration and quicker response times, and that was really supported by the quantitative data that Suzanne has already shared with you. It was also felt that the use of this program will go on to lead to decreased occurrence of failure to rescue, which was the goal we were hoping for when we started this, and a decrease in morbidity and mortality. There were so many lessons that we learned throughout this journey and while we developed and implemented VitalScout. One of the early lessons that we learned was the importance of identifying key leaders who could really understand our vision, because not everybody could see our vision, and then could help us to move this project forward. And Dr. Hamilton and Dr. Collier, who spoke earlier, were 2 such leaders. Critical to the program's success was the way we educated caregivers. While the technical aspects of the program were shown, the education focus was really on patient safety and how do we use this technology to support critical thinking, situational awareness, communication, and decision making. The immediate adoption that we had of this program at all hospitals, as well as the very positive caregiver feedback, really supported the benefits of using this education method. We also learned the importance of having a change management strategy as we went live with each of the 9 hospitals. We wanted to ensure a standardized rollout, so we developed an evolving playbook, and that really provided step-by-step guidance and resources to the hospital team. But as Suzanne mentioned, we also recognized that each hospital has a unique culture, and they were each going to encounter different challenges in rolling this out to their hospital. So the enterprise team partnered with each hospital team, and we addressed those challenges during and throughout the rollout and even afterwards. Our development team was very diverse. We learned the importance of having all end users at the table, and Suzanne spoke very clearly about that, and the importance of providing discipline-specific input in the program. And this really meant that our IT analysts sat at the table and worked side by side with our nurses, our physicians, the educators, and our leaders as we developed this. And then using an iterative approach was truly key. The bedside nurses at Medina Hospital were involved in testing during the development phase, and then changes were made in real time based on their suggestions. And then as we went to each new hospital, the program feedback that we received was actually investigated, and if it made sense, and we went ahead and we actually implemented that and integrated it into our program. Making timely program changes really resulted in constant program evolution and that improvement to ensure that it's going to continue to meet the needs of our end users. That promote the successful development and implementation of a program such as VitalScout. And the first is empathy, and I think Brent mentioned that. Team members must understand the problem from the user's perspective in order to create a solution that's going to be viable for their workflow. And next, everybody on the team has to be vested in the success of the project. For VitalScout, this started, as we did today, with telling a patient story and helping the team members to really understand the problem and then to envision the impact that their work could have on improving patient safety and outcomes. This really created ownership and personal accountability for ensuring the quality of program. This became very personal for everybody on the team, and we were very passionate about the work that we were doing. Finally, we learned the value of resilience and perseverance, the need to stand up for what you believe in, to support and encourage each other on the team, especially when others are questioning your work, and to never give up. And it all comes back to this, the patient story. VitalScout began with one patient, one event, and an interdisciplinary team passionate about improving patient safety around the identification and timely and appropriate intervention for early signs of clinical deterioration. This program was not developed to meet regulatory requirements. It was developed because it was the right thing to do, because we as a health system wanted to provide safe, quality care to all of our patients. This slide shows the impact of VitalScout. Had VitalScout been in place for this patient, caregivers would have received multiple alerts for signs of deterioration, with each alert then requiring a nursing assessment. The report would have provided the nurse with information to critically evaluate the significance of the change and the need for them to intervene, and then the patient would have been reassessed within 2 hours. Additionally, screensavers would have alerted all caregivers on the unit and the nursing supervisor to changes in the patient's status so that everybody would be able to respond. Been in place, the outcome for this patient may have been very different. But today, because of VitalScout, our patients have this increased level of safety if they experience signs of deterioration.
Thank you, Kathy, and that concludes the presentation. Thank you all very much.
Hey, thank you very much. You all, great presentation, and looking forward to sharing this with the public.
Excellent. You can see the slides then.
Yeah. I just want to remind folks where to go find other Davies use case webinar recording. That information can be found on how to on the HIMSS Davies website, and that information, along with information on how to apply for Davies Award, can be found posted at the HIMSS Davies Award website, hims.org/Davies. Thank you so much. Yeah.